to the AEP Upper GI SBRT course. And I'm really excited to introduce everyone to Dr. Michael Chong, who's here from Miami. He's the medical director of the medical director of proton and photon therapy at the Baptist Health South Florida Radiation Oncology Department. He's professor and vice chair of education and clinical research at the Florida International University, and he earned his medical degree from the University of South Florida College of Medicine, and after that completed his residency training at the H. Lee Moffitt Cancer Center. He's an internationally recognized expert in radiation therapy for GI cancers. He is invited globally to speak about his clinical expertise and his research, especially related to proton therapy and MRI-guided radiation therapy. He has published widely and is principal investigator for multiple national and international clinical trials exploring advanced radiation therapy strategies and unique combinations of radiation therapy with novel therapeutic agents. He has received numerous awards, including the ASCO Merit Award, as well as the Moffitt Cancer Center Research Symposium Clinical Research Award. So, welcome. We're very happy to have you here.
Thanks, Ella. Turn the camera off. So I first want to thank Laura and the entire Princess Margaret team for the invitation to be with you. I was here years ago as an attendee and got to see firsthand the quality of the course and the fact that you have representation from Australia, Asia, Africa, Europe, and North America here today is truly astounding, and it's a testament to the quality and renown of the course here. So it's truly a pleasure to be a part of the course and be able to share our experience with MR-guided radiotherapy. So here are my disclosures. Really, the only relevant ones are my my research funding and honoraria from VRA, which is the industry partner for our MR-Linac. So I always like to take a look back before taking a look forward at where we've come, because it really puts things into perspective in terms of where we're going and where we are now. So actually, does anyone know who the picture of this gentleman is? I'm looking at the Princess Margaret folks. So this is Harold Johns. So Harold Johns, I think, was a former chair in the department and led the physics group, I think, before that. But I think historically, if you look at back many years ago, comments like, if you can't see it, you can't hit it, and if you can't hit it, you can't cure it, really are profound, especially in the context of the fact that IGRT is a relatively new advent, right? So the first use of linear accelerators was in the 1950s, and really widespread use of cone beam CT wasn't really until, for the last maybe 10 to 15 years that has become more routine, and obviously today that is now commonplace. And the use of cone beam CT really has transformed how we fundamentally treat certain patients and has enabled dose escalation and ablative radiotherapy to the point now where ablative long SBRT, for example, produces similar outcomes for early stage non-small cell lung cancers. SBRT for liver cancers can achieve curative outcomes. And we know the data from the RTG 1112 show survival benefits using SBRT for liver, driven by image guidance using cone beam CT. But clearly there are limitations in our ability to target lesions and to visualize tumors with cone beam. So I'm going to actually start with a what would you do scenario. So this is a patient who came to me. He had a bladder cancer that was resected, ended up having a recurrence in the mesentery, had chemotherapy for a long period of time, had 22 cycles of atezolizumab, and had no other progression except for this mesenteric nodule. And the question on tumor board was, would I treat this patient knowing that, assuming that I only had cone beam CT, or assuming that you only had cone beam CT, and assuming that, we'll just make it up, it's going to be a 5-fraction regimen, which of these would you choose to treat this patient, knowing again that this patient had a long interval with only this one side of disease, has run out of options, has progressed on systemic therapy? Would you pick any of these, or would you pick F? So by raise of hands, who picks F? Would you treat this patient? So there's a number of hands that where there's some uncomfort with being able to, number one, visualize this lesion on cone beam, right? Be very, very difficult to do. And I would certainly argue I wouldn't probably pick any of these in terms of dose, except for possibly 4 or 5 grade times 5, if I were to if I was forced to treat this patient, right? But clearly that's not an ablative dose. It's not really a high dose. It's not one that's going to provide meaningful long-term tumor control. And it really, I think, is an extreme example of the uncertainties that we have, and how many uncertainties drive how we treat patients or how we don't treat patients, right? So inter and intrafraction variability obviously are key drivers of how we fundamentally treat patients. And what we do a good job in today is accounting for interfraction variability in terms of setup error in the top left corner. But we really don't do a great job in terms of organ motion. There are motion management strategies, but I would argue that they are really not optimal because a lot of them use surrogates to account for motion or to assess motion. And certainly intrafraction variability, because of the lack of intrafraction imaging, really is not a routine ability today. So when looking at certain tumors, especially those near critical structures in the abdomen and pelvis, we are certainly limited by these uncertainties and the doses that we can prescribe. So for example, pancreas tumors in the top left, a liver metastasis in the top right, nodal disease in the bottom two panels. And clearly the desired dose that we are thinking about isn't necessarily the same dose as the safe dose that we ultimately prescribe. So these lesions would routinely be treated with arguably non-ablative radiotherapy using CT guidance. And I always sort of feel like, as a GI rad onc, I kind of feel like Steve Carell on the left, where, you really want to give more than you are probably limited to, but there's uncertainties there and you don't want to cause patients any harm. And then I contrast this feeling with how my CNS colleagues are looking when they're gamma knifing brain mets and single fraction ablation and whatnot. And there's clearly a discrepancy in how we view dose escalation. And it really is, I think, even if you go back many, many years, the use of ablative radiotherapy for intracranial lesions and spine lesions and more immobile lesions really has been pretty routine for a long time. This publication in 1954, I think, highlights that, and it states that brain metastases have for years afforded one of the more striking successes of radiotherapy, but liver metastases have always been regarded as a hopeless proposition because of, obviously, concerns of causing toxicities. And so while intracranial SRS began in the 1960s and has been a standard of care for decades, ablative radiotherapy in the abdomen and pelvis in particular is still very limited to select tumors in 2023. So how do we bridge the gap and improve the outcomes for especially our abdominal pelvic tumors? Going hand in hand with IGRT is the ability to deliver highly conformal therapy. So clearly dose limitations many years ago when delivering non-conformal therapy, there were significant limitations in terms of the total dose and needing to deliver split course therapy with a 2-week break in the middle. And obviously we have now improved our ability to deliver conformal therapy, making the importance of IGRT even more critical, especially knowing that high or steep dose gradients here for very conformal therapies requires precise and accurate targeting. So while we can deliver conformal therapy, so for example, for pancreas cancers, still non-ablative radiation therapy is routine. So looking at the ASTRO clinical practice guidelines for pancreas cancer, for example, for an unresectable locally advanced tumor, the recommendation is somewhere around 33 to 40 gray in 5 fractions, which is a BED somewhere around 55 to 70 gray, which arguably is not ablative. Even when ablative dose prescriptions sometimes are recommended or pursued, the percentage of the tumor or the volume of the target that receives ablative dose many times is limited to areas away from the bowel, and in many cases is not covering the majority of the tumor. So this is an example from the Alliance Borderline study that Joe Herman and I were a part of, where we intentionally, there was an intentional dose escalation using an SIB approach really only to the tumor vessel interface and not to the entirety of the tumor. And that really is to avoid or minimize toxicities with regards to the bowel and to the stomach. The other point I think worth mentioning is the discrepancy in the target volumes that we routinely use. Actually, I'm sorry, let me close that. The target volumes for SBRT, for pancreas cancer and other tumors, does not necessarily match that of standard fractionation therapy, right? So the recommendations here, and you can see the implementation remark, is that SBRT does not routinely treat elective nodes, but conceptually that never made sense to me because we do it routinely for locally advanced disease that's treated with conventional fractionation, and it really comes down to minimizing toxicities. So again, there's a contrast between non-ablative therapy and ablative therapy. And why is that discrepancy so profound? It really comes down again to uncertainty. So on the left, we have mobile target, we have mobile organs at risk, we have no routine intrafraction imaging. The bowel and the stomach that many times abut your tumor are exquisitely radiosensitive, and the quality of cone beam CT again is really suboptimal. On the other hand, the certainty, because of the rigidness of the target and the OARs for intracranial lesions, despite having no intrafraction imaging, allows for greater confidence to deliver ablative doses versus uncertainty on the left. So it really comes down to, are we certain that the conformal dose that we're delivering is going to tumor and not going to organs at risk? How do we account for this uncertainty? So we already mentioned that dose reduction is routine. We will sometimes use larger margins, and we can fractionate more, and that can account for this uncertainty to some extent. But nonetheless, non-ablative radiation prescription dose for many tumors in the abdomen and pelvis are limited to, again, non-ablative dose. And why is that? And where did these constraints come from? It's not a coincidence that the prescription dose, whether in 5 fractions or 3 fractions or 28 fractions, really is very similar, if not the same, as to what your organ at risk constraints are regarding the stomach and the bowel. And I just pulled up examples of ongoing NRG trials just to give you an example of what that looks like. So a prescription dose of 30 gray or 33 gray in 5 fractions is pretty routine in the abdomen and pelvis near the bowel, and that's the reason behind it. But nonetheless, the goal of delivering higher doses, I think, is still there, and the data will support dose escalation for many tumors in the abdomen and pelvis, even though we conventionally are limited in the dose that we can deliver. These are data from the high-tech publication that was published a few years ago, showing an example of 12-month local control in unresected pancreas cancer patients, showing a dose-response relationship, suggesting that dose escalation improves local control for these patients. As Dr. Tsai mentioned yesterday, and as I'm sure you're all aware, oligometastatic disease, especially tumors that are more radio resistant, for example, colorectal cancers, certainly benefit from dose escalation as well. So just because there is a nodal metastasis from a colon cancer up against the bowel, delivering 30 gray in 5 fractions probably is not sufficient, right? And really is not ideal in terms of long-term disease control, but we limit doses to that range really because of safety. Ideally, we would want to deliver higher doses than that. In terms of oligometastatic disease, if you look across the trials that have been published, have ablative doses been uniformly prescribed? The answer is no. So if you look at the most common fractionation in the SBRT COMET trial, actually about 50% of patients were prescribed 35 and 5, which arguably is not ablative. The other limitation in the oligometastatic data are that the lesions, in terms of location that are treated on those trials, really are not a broad representation of where in clinical practice we see these metastases, right? So the metastases that are treated in these trials are typically limited to liver, lung, and bone, really because we can get away with delivering ablative doses safely there. But we see, and I know many of you, if not all of you, see many patients with oligometastatic lesions in other locations outside of this, whether adrenal glands or lymph nodes or other locations. So could we improve the ability to treat those patients? Now, of course, the fear of dose escalation is causing toxicity, right? So causing bleeds, ulceration, perforation, that could be grade 4 or grade 5 toxicities, clearly are what we want to avoid and why we don't escalate dose to uniformly to tumors in the abdomen and pelvis. There have been attempts to dose escalate tumors. For example, there was a Dutch trial, fairly small, but a BED10 of 112 gray in 3 fractions rather, but really was not did not use contemporary volumetric imaging. And you can see that the majority of patients had pretty significant toxicity. The conclusions that the authors published were that there was really no benefit to doing this at all, and really was not, they were not very optimistic that this should be or would be commonplace or should be pursued moving forward, although we since then have obviously found benefits to delivering SBRT. A more contemporary phase 1 trial in pancreas cancer patients using cone beam CT with smaller margins also showed that despite more advanced image guidance and smaller margins, there was still grade 4 and grade 5 toxicity in the study, demonstrating that we do still have to be cautious. But really, what is the underlying cause of these toxicities, and really what are the challenges that we have to address? So one is obviously the interfraction anatomy. So how your simulation anatomy looks is for abdominal and pelvic tumors, most of the time is not, and almost all of the time is not what it will look like on the day of treatment, right? So especially if you're treating tumors in the pancreas, if you're treating tumors in the adrenal gland, if you're treating tumors in part of the liver, how the bowel is positioned on any given day will vary to some extent. These are data that we published, I guess, last year, looking at predicted doses to organs at risk in our pancreas cancer patients treated on our MR-Linac in terms of what would have been delivered if we used the original plan on the current day's anatomy. You can see the X's represent wildly, volumes of those OARs that wildly exceed the 0.5 cc constraint. That's the horizontal line on the bottom. Because we were able to adapt the plan, and we were able to meet those constraints. But really the point being that significant interfraction variations lead to potentially large and severe violations of the OAR constraints. The other limitations, of course, are the inability to have to image patients during treatment with cone beam CT, right? So there's that uncertainty as to whether or not we are going to hit the target. So effectively, we're blindfolded, right? So sometimes we'll get lucky and we'll hit a bullseye, but many times you're not so lucky, right? And probably more times than not, we're not so lucky. So that's another limitation too, right? So uncertainty of what's actually happening while the beam is on, as opposed to what's happening on the pre-treatment imaging each day. And then last but not least is, abdominal and even pelvic tumors are subject to potentially significant motion. We just had a great talk on that a few minutes ago. And the way to account for that is or one of the common ways to account for that is adding a margin, so an ITV, and then adding a PTV on top of that. If you have a tumor that's mobile near radiosensitive bowel or stomach, that, of course, these margins will account for that motion and ensure that we're not going to miss, essentially. But that means that you are going to inevitably deliver more dose than you would want to organs at risk nearby. And so really, ideally, we would want to treat patients with as small of a margin as possible, both in terms of potentially eliminating the ITV and using smaller PTV margins. So to put that all into summary, the limitations of current CT-guided SBRT are suboptimal soft tissue contrast, no interfraction imaging, needing surrogates to assess and manage tumor motion, and not being able to in a rapid period of time, while the patient's on the treatment table, adapt treatment to account for interfraction anatomic change. So what if we could change all of that and address each one of those? Wouldn't that be transformative to the field and how we treat these patients? And the answer, or one of those answers, is MR guidance. So MR-guided radiotherapy really addresses each one of these limitations. So the soft tissue contrast of MR is well known to be superior to CT. There is continuous interfraction imaging. The GTV is directly visualized, and its position gates the beam. So there is no need for an ITV if you have an automatic beam gating solution. And online adaptive replanning is routine. There are two commercially available and clinically used MR-Linacs on the market. One is the ViewRay Meridian Linac, which we have at Miami Cancer Institute. The other is the Elekta Unity, which of course is here at Princess Margaret, and and both of these systems have numerous installations throughout the world. The MR imaging that I'm showing you here really needs no explanation. The soft tissue contrast here is clearly superior to CT, and I would note that these are images acquired without IV or oral contrast. So the inherent T1 and T2 capabilities of our TrueFi sequence on the left and the T1 sequence on the right, I think, speak for themselves. Just some examples of CT versus 1.5 or 1.5T imaging. You can see here just to show really how superior the MR imaging is to seeing fine details in soft tissue. These are images from our center with our Meridian. You can see that, again, the image on the right is without IV or oral contrast. So the TrueFi sequence with its T2 component really shines the water content in the lumen of the duodenum. You can see here very, very clearly. So there is no need to give oral contrast. And clearly the differences between the CT image on the left are, again, speak for themselves. And here are some other images just to give you a sense. Just to give you also a sense of what the interfraction imaging looks like as well. So let me Let me go back. So these are images from Unity and from Meridian. Again, these are images acquired throughout the entire course of treatment. So if there is any motion at all, we will see that. The Meridian Linac is able to automatically gate the beam. So we are able to treat patients either free breathing or in breath hold, and the machine will automatically turn on and turn off based on the position of the tumor or any other structure that we identify. The Unity system recently now has a motion management component. The first patient was treated, I believe, in Utrecht for pancreas cancer, and that will become more widely available. And certainly I'm curious to see how that is implemented by Unity sites. You know, one thing that we've done, because our patients are almost exclusively treated in breath hold, is I thought, you know, this was a few years ago. What if we give patients O2 by nasal cannula, even if you're not O2 dependent? And that actually has now become a standard of care over the last several years. It really significantly helps the breath hold times. And we did tests, some of our therapists and we just try to hold our breaths. We did time tests with and without. It's typically 2 to 3 liters. And you can potentially double your breath hold times with the O2. So that has been a standard at our center for some time. Again, I mentioned the Unity motion management solution. These are images just from our system to give you a sense of what this looks like. So we can track tumors not just in one plane, but in multiple planes. So potentially we could have a third view here, sagittal, coronal, and axial. You can see here on the bottom middle where it says beam on. So the system automatically will gate the beam based on the position of the tumor. And you can see the MLC pattern on the bottom left. Not only can we track tumor, we can actually track normal tissues as well, okay? So actually, this is a great example of a lymph node on the right that we're tracking during treatment, okay? And that really doesn't move at all. It's pretty stationary, okay? What you see here on the left, this is actually bowel. So we're tracking bowel in one plane, tumor in the other, and the blue line here represents a 35 gray isodose line. So if the bowel actually moves into and overlaps with the isodose line, the machine will gate off. Or if the tumor itself moves, the machine will gate off. So really incredible ability to track not just tumor, but also organs at risk and even use isodose lines as tracking structures. The patients have an interactive sort of relationship with treatment, I guess you'd call it. So this is a monitor on the back of the wall outside of the bore. You can sort of see it through the bore here. And what it shows the patient is what I just showed you on that cine MR. So they actually will see their tracking structure, the boundary, and we will give them education before treatment about how they should be breathing, holding their breath so that they know they need to get the tracking structure inside basically the target. And so it's sort of like a video game to describe it, you know, so they sort of get to have an interactive participation in the treatment to turn it on and off. And that's really been well received. So this gives you a sense of what the patients see for the same case. So that tracking the bowel on the left, and this is as the gantry rotates, the patients will see that. But and there's a smiley face emoji, which is kind of cute, to tell them that they've done a good job and to hold their breath in that place. So that's really been beneficial. And actually, a bonus of this system has been that claustrophobic patients, because they're not seeing the bore right above their head, and they're seeing the big room outside of them with the monitor. It's been a significant help with claustrophobic patients in getting them through treatment. And then last but not least, in terms of the capability of an MR Linac, is this is the typical workflow, right, of our treatment, where we sim, contour, plan, QA, and then deliver the same plan each day, regardless of any interfraction changes. But you know, ideally for tumors in locations where there's a lot of interfraction changes, we would be doing something like this. And that's really where the ability to adapt treatment without patients getting out of the treatment position really is powerful. So this gives an example of one of our pancreas patients, prescribed 50 gray and 5 fractions. You can see there's a pretty good hotspot. So this is the 120% line, this blue. Here's 40 gray and 5 to give you an example. And this is the original plan. So when the patient came for the first fraction, this is what it looked like in terms of the predicted. So if we use the original plan on the anatomy from that day, obviously the duodenum would be wildly exceeded in terms of the constraint. So within a few minutes, we're able to do something like that. And you basically will repeat that process day after day after day. And so obviously this allows us to minimize dose to normal organs and to meet dose constraints. But the other important consideration too is that we are delivering ablative dose to the vast majority of the tumor at the same time. So you can see, actually I didn't. So you can see here that the bolded line is the 40 and 5, but you can see there's still, a 60 gray hotspot here. And actually our max planned doses tend to be upwards of 70 plus gray. And the 50 gray and 5 line is the red sort of inside the 40. And I'll show some more examples of our treatment plans. What is the benefit, and how can we quantify the benefit of adaptive replanning? This is a publication that one of our research fellows, Larry Rodriguez, led in adrenal patients treated on our MR-Linac who were retrospectively planned using the same targets, but with CT guided, or with the assumption that they would be treated with CT guidance, either in breath hold or free breathing, really to look at, what is the effect of motion, number one, and then two is just differences in planning between MR and CT. And the long story short is there was a significant number of patients, and in fact, between 70 to 80% of patients, where there's an indication to adapt treatment, whether it was because of violating OAR constraints or because of inadequate coverage of the targets or both. Because we are able to adapt treatment, obviously, we were able to meet both the dose constraints and maximize target coverage. But you can see here in the CT guided plans, even in breath hold, upwards of over 70% of patients, there would be an indication to adapt treatment. And that really is because of the interfraction variability in anatomy. Just really quickly in terms of the sort of the evolution of MR guidance, this obviously is it's a novel technology. It's a relatively introduced technology going back to the Meridian system, which was the first MR-Linac commercially available back with the first treatment at WashU in 2014. We at MCI were the second Meridian Linac site in the country, starting treatment in April of 2018. So we're actually coming up on our 5-year anniversary next month. And time flies, and I can't believe it's already been 5 years. So I've shown you what the capabilities are of this technology. How have centers used this? So this is a patterns of utilization study from the Electa Momentum study, which is a registry study showing the utilization across different sites. And not surprisingly, the majority of these sites are in the abdomen and pelvis, right? So these are sites where there's significant interfraction variability, where there's motion, and there's advantages for MR. A predominance of prostate and lymph node treatments, as you can see here, and the ability or the utilization of what's called adaptive shape or plan reoptimization, as you'd expect, would be mostly for pancreas cancers and lymph nodes near bowel, and some rectal cancers as well. We also did a patterns of utilization study across Meridian centers that was published last year. And you can see over time, from 2014 to 2020, a greater utilization for pancreas cancers down here, also a growing use for prostate cancers, and a decreasing use for breast cancers. So, I think the Meridian sites had figured out really the benefit of treating patients with moving tumors really was a main priority for a lot of centers, and that's why you see tumors like prostate, which can move substantially actually because of rectal gas distension, et cetera, and pancreas cancers and other abdominal cancers. You can see here utilization over time. What I'll point out here is that this is total courses here on the right column. The vast majority of treatments delivered are ultra hypofractionated, so 5 or fewer fractions, which makes sense. So these are heavily SBRT focused types of treatments. And on-table adaptive replanning, which is the blue column here, you might expect to be higher. I don't know, well, at least if I didn't have an MR-Linac, I might have assumed that that you're adapting every single patient just because you can. But in fact, it actually is. It's not all patients, right? It's somewhere between 50 to 60% of patients. And I think probably what that is coming from is the utilization of Meridian, not just to adapt, but also because of the motion management component. So at MCI, we will triage patients who have moving tumors, even if we don't expect to adapt, to our Meridian because of the ability to automatically gate the beam. And that's even for peripheral lung lesions that we don't expect to adapt. These are trends over time of utilization of ultra hypofractionation. And really, I think the takeaway here is that there was much more 15 fraction treatment and more fractionated treatment early on. And I think as the early clinical outcomes showed, really no significant toxicity despite dose escalating. Really, the movement was towards 5 or fewer fractions. So we at MCI have, as I mentioned before, one of the original Meridian Linacs in the US, but that's actually among assortment of other advanced technologies. So all of these, including proton therapy, CyberKnife, Radixact, TrueBeam, Gamma Knife, all exist in the same department in the same physical space. So you might ask, well, how do you decide between one or the other? And at the end of the day, I think the themes are moving targets, dose escalation, and shorter fractionation is really the bread and butter of where we have decided to put our patients on Meridian. So in the beginning, we had no idea, and I had no idea what our MR-Linac was going to be used for. I had a sense it would be SBRT, but you can see a smattering of different cases among our first 9 patients starting in April 2018. And at least my initial strategy or thought was, I knew I didn't need fiducials. We could probably use a relatively small PTV margin. I didn't need an ITV because of the automatic beam gating. And that was really about it, to be honest with you. And we treated patients just to kind of see what we would see. And we actually didn't even have an adaptive program in the beginning, just as was common back, a few years ago, which we didn't know what to expect even with non-adaptive radiotherapy. That, of course, has evolved. And so now this is what our patient portfolio sort of looks like. So the majority of patients by individual disease site are pancreas cancer patients. These are typically patients who have either borderline, but more commonly locally advanced unresectable pancreas cancers. And then you see a smattering of lung, lymph nodes, liver, and adrenal. So the vast majority of these are oligometastatic lesions. So the vast majority of what we treat are metastatic lesions in our center. And really all of these are treated with the thought that these are moving tumors and or are near critical structures, and we want to try to dose escalate these. And we would be able to do so more safely with our MR-Linac as opposed to a CT-based approach. So what have we learned over 5 years? So again, Meridian is our preferred technology for moving targets, whether that's a lower lobe lung metastasis that we don't expect to adapt, or other tumors. We've now become, at least I've become confident and comfortable that ablative radiation dose, even in 5 or fewer fractions, is safe in the abdomen and pelvis using adaptive replanning if we need. MR guidance expands which tumors are eligible for curative intent therapy. So whereas I might otherwise prescribe 5 or 6 Gray times 5 for lesions, the routine prescription dose for nearly all of the metastatic lesions or pancreas cancers or whatnot that I treat is effectively 50 Gray and 5 fractions, or an equivalent of 100 Gray BED or higher. Shorter fractionation is something that we've focused on, and I'll show you a little bit more of that. And it has benefits, obviously, to our wide group of patients, providers, and also payers. And at the end of the day, I think the theme is that you have the confidence to deliver the dose that you really ideally want to deliver, and deliver it with confidence that it's going to be safe. So pancreas cancer is the #1 indication I just showed you on the pie chart. And these are not tumors that we're typically treating that are 2 centimeters or 3 centimeters small. These are tumors that are coming to me and to us that are 8 centimeters large, or 9 centimeters large, or 7 centimeters large. And so these are tumors that may otherwise not be offered even SBRT with cone beam CT. So the ultimate question is, does ablative radiation dose improve survival for unresectable pancreas cancer patients? And prior studies like LAPO-7 and others, the CONCO-7 trial, have not shown a clear improvement in OS, at least with non-ablative radiation dose. And there is some emergence of data from MD Anderson and some other institutions suggesting that a BED of 70 or higher may be associated with improved overall survival. And the rationale for that is that even if you have limited metastatic disease, that about 1/3 of deaths are due to local progression. So there is morbidity and sometimes mortality from uncontrolled tumor growth in the pancreas. So you can cause sepsis, cholangitis, obstruction, bleeding, et cetera. And so improving local control or preventing tumor growth potentially could impact the survival of a select subset of patients. So in 2018, when we first started our program, this is sort of what the tumors look like and the target volume. So the point being, relatively smaller tumors. I was treating a GTV plus a 3 millimeter PTV, relatively confined. And I didn't know what 50 Gray and 5 fractions was going to do to patients, if they were going to tolerate it well or if they were going to be miserable. And it turns out they tolerated it just fine. In contrast, this is what volumes look like at MCI today. So treating larger tumors, sometimes with extensive nodal disease, and also with the CTV. So CTVs have become routine, and actually started being routine in my practice in 2019. It's typically treated using a dose painting approach. So my current prescription for these tumors is 50 Gray to gross disease and 33 Gray all in 5 fractions to elective areas. And I'll show you some outcomes of that. But this is what the evolution has looked like over 5 years. And again, just to highlight the point that, we're delivering ablative dose not to small, tiny tumors, but rather to large extensive tumors. And still, the outcomes that I'll share with you are quite provocative. The segmentation and the simulation for these patients is all done on our MR-Linac. And actually, within the last 6 months or so, we've actually moved to an MR sim only workflow for our abdominal tumor patients. So we don't CT sim these patients anymore. They are treated with both arms down just for patient comfort. Just a really quick summary of how we plan these patients. So there is typically a 3 millimeter PRV that's placed on the GI OAR structures. There's an optimization structure for any overlap of the PRV with the PTV. We will create an opti structure that basically subtracts out that overlap. The same happens for the GTV. And then we intentionally will plan these plans hot. So we don't want homogeneous plans. We want sharp dose gradients. And part of that inherently is that we will deliver hotspots to the core. And so that is a subtraction of 3 to 5 millimeters to create an optimization structure to drive the hotspot. So you can imagine if you don't have abutting OARs, that the hotspot actually can be pretty large and if not cover the vast majority of your target. And this is sort of what some of the isodoses look like. So we do confine the 50% isodose line you see here. So this is a ring structure that we use. The blue is the 120% isodose line, so it's relatively large, and the red is the 50 gray or the 100% isodose line. So they are pretty hot plans. Here's an example of a patient who came from across the country for her disease because they didn't feel like they could treat it adequately where she was. But just to give you a sense, the maximum GTV dose was in excess of 70 gray. Mean dose was 55. As I mentioned before, the majority of the target receives at or near prescription. So it was 82% covered by the prescription isodose line. These are what our dose constraints have been. I will admit to you, I sort of made them up based on what conventional sort of constraints I was using with CT guidance, with the rationale being if I can adapt the plan each day, probably I can get away with giving a little bit more. So 40 gray point doses to these structures has been routine to the stomach small bowel duo, and large bowel is a little bit higher. So this has been in place since 2018, 2019, and all of our clinical outcomes are based on using this. One word of caution, and this came up in the course earlier, is just the importance of contouring these structures accurately. So what is a representation of what we don't want to do is on the left. So you can see that the luminal contents are really what's focused on in the stomach. For example, the entire wall or the thickness of the wall of the GI structure was not contoured here. It's a very common mistake. But if you're delivering ablative dose in the middle of the small bowel, the duo, and the stomach, you better be sure that you identify your organs at risk correctly. Otherwise, you can cause significant harm. And actually, the example on the right, let me display that here as opposed to the left. So you can see the differences would be, contouring not the luminal contents only, but the full thickness of the wall of your GI structures is critical. So there's a really great MR-based upper abdominal organ at risk atlas that Yelena and Laura and others put together. So I would really encourage folks here to reference this and look at this. Also, econtour.com, it's econtour.org, sorry, is another great resource where you can have some interactive scrolling through some of the contours. So really, really recommend that as a resource as well. These were the first 50 gray and 5 fraction clinical outcomes that were published. And they came from our institution a couple of years ago. This was a small number of patients, but still wanted to show that number one, we're not causing harm. So the median dose here was 50 gray and 5 fractions. The first outcomes, again, on an MR-Linac as opposed to MR Cobalt system. And we saw very little toxicity, believe it or not. So it was really under 5%, both acute and late grade 3 toxicity with no grade 4 or 5 toxicities. And the early clinical outcomes in terms of local control were encouragingly good, around 90% or so. I highlighted table 3 here, or I included it here, just to, again, drive home the point that ablative dose is delivered not to 50% or 20% or 60% of the tumor, but really the majority of the tumor, of the target volumes, receive ablative dose that is close to, if not exceeding, the prescription, both on the initial plan, but across the adaptive fractions. We updated our clinical experience. I didn't put the clinical outcomes data here. Last year in patients who received induction chemo followed by 50 gray and 5 fractions, again, included another table just like this with updated metrics, really driving home the point that these are truly ablative. This is ablative coverage to the majority of the target. But it's still amazing to me to see how well these patients tolerate treatment, even older patients. I mean, I've treated a number of medically inoperable patients who have relatively small tumors and some with large tumors who are not candidates for any other treatment, who have been told by their oncologists and surgeons that, they should just go to hospice and, sorry, I can't do much for you. Who will get ablative radiotherapy in 5 fractions and have incredible outcomes and tolerate it extraordinarily well. So we combined our data with Moffitt Cancer Center in patients who were a bit older, so the median age was 81, ranging up to 91. And we saw really no concerning grade 3 or higher toxicity, and a lot of these patients didn't even have grade 2, and some did not even have grade 1 toxicity. This is a patient of mine who I don't know if the audio is going to come through, but yeah, let me just play it. So this is a patient who finished treatment, just to give an example of how well these patients tolerate treatment.
This is Stephen White. I started MRI-driven radiation for pancreatic cancer with Dr. Chung at Miami Cancer Institute in October of 2022. The treatments lasted for 5 consecutive days, with each session from 30 to 45 minutes. During and after the treatment, I had no discomfort whatsoever. The only side effect I had was mild fatigue for the last couple of days of treatment. My results have been excellent.
So I'm glad to report Stephen's CA19-9 went, I think, from 400 or so down to 7 now. And his experience is actually very, very common. So patients will have a little bit of fatigue, maybe some mild nausea, but there's a lot of patients who that's really just it, and believe it or not, there's a good number of patients who sail right through treatment without actually telling me they have any side effects at all, despite the aggressive dosing. This is just another patient who, just to give you a sense, I mean, these patients who we're treating really have no downtime. There's a lot of patients who come to us internationally, just to give you a sense, who will fly in, get treated, 5 fractions, fly home the next day, and feel perfectly fine. So we are not causing patients, major toxicities despite the volumes that we're treating. The phase 2 SMART trial was reported at ASTRO last year. This was a multi-institutional international trial of 50 gray and 5 fractions across Meridian centers. This enrolled 136 patients. All patients required to get chemotherapy first. The CA19-9 criteria was a bit lax, although the primary endpoint was safety. So, but the prescription again was 50 gray and 5 fractions with an optional CTV. And Prague-Peak presented the primary outcome last year at ASTRO, which was acute grade 3 or higher toxicity, definitely related to SMART. And that, surprisingly, and I'll be honest with you, I'm involved with the trial. I think we were all surprised that was 0% in terms of definitively related grade 3 or higher toxicity. When you look at possibly or probably, that was under 9%, which is really in line with what you'd expect from non-ablative SBRT. So really a positive and really strong early signal that what we're doing is not causing patients harm. And in fact, we're encouraged to move forward with future studies. And that leads to the efficacy outcome. So if this is a safe treatment, are we benefiting patients by dose escalating? These are data that have not been published yet, but looking at our own recurrence rates, both in terms of local and regional, over a period of time, we have not seen a significant number of patients who have recurred over a multi-year period of time. In fact, we saw about 15% of patients had local regional failure. Most of these patients were treated with elective coverage. And where you see these patients recur, you can see here both primary tumor, but also some regional lymph nodes. But really, I think the kicker is that if you look at infield versus marginal versus out-of-field failures, only one patient had an infield failure, and that patient actually was not treated with the CTV, okay? All the patients treated with the CTV did not have infield failures. And in fact, the vast majority of failures were marginal or out of field. And one of the areas that I had not been treating electively is the porta. So actually, since looking at our data, I have started to expand my CTVs even a bit more and include more of the porta actually, which has seemed to be well tolerated so far. And this just gives an example. So this shows you the 33 gray isodose line around the GTV. This is one of my earlier patients where the CTV really wasn't that large. And here you can see a recurrence contoured out in the porta. We saw a couple of SMA recurrences, SMA and celiac recurrences are among the more common locations for recurrence. And actually, all of the SMA recurrences were right at the distal SMA outside of the CTV, where the first adrenal branches come off of, which is a very unusual place for recurrence to happen in an isolated fashion. In terms of long-term local control and survival, this was maybe 2 or 3 years ago now, presented a multi-institutional outcome presentation demonstrating 2-year survival of over 50% in these patients treated with 50 gram 5 fractions, suggesting that in fact maybe we are improving survival. I was curious if the hypothesis whether we're reducing local regional failures that lead to death in fact bore out in our own data. So this was published last year where we looked through causes of death in our locally advanced patients as far as whether they were from local regional causes or distant metastatic causes or others. And you can see here that local regional cancer progression as a cause of death was only about 7% of patients, which is much lower than historical and much lower than the 33% or so that I showed you from the Hopkins autopsy study from before. So there's a hint at least that maybe we are impacting survival because of helping to control local regional failure better. So really excited about the LAP-ABLATE trial. So this is a phase 3 randomized international trial that is a sponsored trial by ViewRay. It's a trial that is looking to show whether in fact ablative radiotherapy improves OS as opposed to chemotherapy alone. So essentially recapitulating LAP-07 with ablative radiotherapy, where patients are randomized to one or the other. It's a 2-to-1 randomization after induction chemotherapy. And you can see here that there's additional chemotherapy and surgery that are permitted afterwards if deemed appropriate. In the no chemo arm, we are permitting patients who have local progression only to receive ablative radiotherapy as per the RMB. And there will be a separate statistical analysis for those patients. Another unique aspect to this trial is you could argue that, the original plan that you come up with, if you're adapting essentially every fraction, is you don't really care about the original plan, right? So doing QA on the original plan obviously is important, but really what you care about is the adapted contours and the adapted fractions. So this trial is mandating both rapid QA of the original plan, but also the first 3 patients from every site of the adapted fractions and the adapted contours to ensure high quality. So that's something that we're quite proud of. And this is a trial that is opening imminently across the North America and Europe in particular. This is our PI team. Really proud of the team we put together, including a number of renowned medical oncologists, including Eileen O'Reilly from MSK and Day One Kim from Moffitt. And you can see the rest here. Last but not least, before we round out the pancreas part of the talk is, we have not seen a significant number of patients progress locally, as I shared with you, after ablative radiotherapy, but inevitably, these patients will progress, and almost always in the liver and in the peritoneum. I mean, that's by far the more common location. We have a phase 2 trial that's opening hopefully in the next week or so at MCI, taking patients who have locally advanced disease, who make it through induction chemo, and then would receive 50 gram 5 fractions, and at the same time begin tumor treating fields, which are delivered to the entirety of the abdomen, including the peritoneal cavity and the liver, as a maintenance therapy out back. So the hypothesis is that we can eradicate or at least delay growth of occult micrometastatic disease in these areas and potentially impact at least progression-free survival. And if there's a signal from this trial, I think there'd be a strong rationale for looking at incorporating tumor treating fields from a survival standpoint. Last but not least, I did want to incorporate some data from the Unity side, so it's not a Meridian only talk, but there is some emerging data, including from MSK and also from the group here at Princess Margaret, of treating upper abdominal tumors, including pancreas cancers, with ablative radiotherapy using an abdominal compression approach, as we heard about recently in previous talks. And the feasibility of this looks to be good. Obviously now with the comprehensive motion management capabilities of Unity coming through, I fully suspect that the workflows will change once that capability is available. So let's switch gears a little bit. We've talked a lot about pancreas cancer. What about other abdominal tumors, especially oligometastatic lesions? So, if this was a lesion that you were sent to treat, say it's a colorectal metastasis, I don't think anyone here would be concerned of treating this with cone beam CT, right? It's not up against the bowel. It's not really near any other structures other than the liver itself. Can easily place a fiducial marker there and have a good chance of a good outcome with ablative radiotherapy. But there's still a challenge that, of course, we're not able to visualize tumors in the liver well. We use surrogates like fiducial markers, to assess position, but really fundamentally looking at and identifying accurately these lesions is difficult. And so, of course, if you're able to identify them more clearly with MR, really there's no good reason why you wouldn't, right? So we have increasingly been using our meridian to treat tumors in the liver, especially because one, they move. Two is because of challenges identifying tumor with CT. Three is we're able to treat these patients again without ITVs and minimize the dose exposure to the normal liver, knowing that as patients live longer and select patients who may come back for additional courses of radiation to the liver, minimizing cumulative dose to the liver is critical. Now, I think we're all well aware that metastatic control or control of metastatic lesions in different organs is different, right? So notoriously, liver metastases are more difficult to control than lung metastases, for example. There's probably some tumor biology to this, but you also have to wonder whether there's some geometric targeting accuracy issues here as well, right? So if you can't accurately or if it's more difficult to identify liver tumors than a lung tumor, maybe you have some geographic miss to some extent. So I think one of the outstanding questions that I'm curious to know the answer to is, even if you're not adapting patients with MR guidance, if you're able to more accurately see tumors, especially as they're moving with MR guidance, does that allow for more accurate targeting? And that's we don't have the answer yet. But clearly, there are more challenging tumors in the liver, for example, those that are in the medial liver up against the bowel and other challenging places that we're not able to safely deliver ablative radiotherapy. And MR guidance can have a benefit there. There's some data out there showing that MR guidance for select tumors, especially those, again, in more challenging locations where adaptive replanning, so that would be, again, tumors up against the stomach and the bowel, it particularly benefit from MR guidance for dose escalation. We do not treat necessarily all of our liver lesions with MR guidance. It really is a select population of patients, especially given that our meridian is there's a certain throughput and we have a lot of other patients who potentially would benefit from adaptive as well, but especially those patients who need to be adapted. For example, this patient who had a metastatic lesion that we prescribed 50 and 5 to, and you can see some changes in the duodenal position relative to the tumor each day, and we were able to successfully treat this again with ablative dose in most of the tumor, and he had a complete response that's sustained over a few years. The outcomes for oligometastatic disease treated with MR guidance, they're still in their infancy. They are emerging with a theme of dose escalation, again, shorter fractionation. We put together a multi-institutional study looking at our practice with Acıbadem in Turkey. And you can see here that most of what we collectively had treated were abdominal pelvic lymph nodes. You can see roughly half of those represented here in the study, as well as lung, liver, and adrenal mets. Short follow-up, but the one-year local control rates are quite good at over 90%, with a median BED of 100 gray and 5 fractions. There are some emerging Unity data. Here is one study from the Netherlands prescribing 5 times 7 gray, showing benefits here of being able to adapt and keep dose constraints met of the bowel and other nearby structures. So clearly a focus, I think, moving forward as we look at MR guidance to dose escalate lesions that typically are not represented well in prior oligometastatic trials outside of liver and lung and bone mets. This is a patient, just to give an example of sort of the power of MR guidance and adaptive replanning. This is a woman who I treated actually a few times who had a refractory adrenocortical carcinoma, who this was just growing out of control and she was having a lot of pain, had a lot of systemic therapy prior. But an example of how you can treat large tumors with ablative dose, even though bowel is literally abutting a large part of this. And you can also see here, again, the 60 gray or 120% isodose line is covering the vast majority of the tumor. And you can see on the DVH how hot these plans really get. And high dose works. So she had a little bit of some temporary, I think, diarrhea, but that was really about it. 1 year later, the images speak for themselves, and radiation was really the only thing that worked for her. And I feel pretty confident that the dose escalation component of this was really significant. This is the case that I showed you in the very first, I don't know, 3 slides. This is a patient who I ended up treating actually a few years ago. He was prescribed 50 gray and 5 fractions, so a common theme. Despite, you can see here the contour of the OARs and the bowel loops coming in and out across the compared to the simulation anatomy across the 5 days of treatment. And you can see how the isodose lines were able to be sculpted around the organs at risk, while still, again, delivering, hotspot here of at least 120. So again, high dose works. So we published this as a case report of the first, as far as I know, mesenteric ablative radiotherapy treatment. And I just checked his chart, and now he is NED 4 years later. So pretty incredible. I actually treated another lesion, just to give an example of the confidence that MR gives you. This is actually the same patient I treated after the mesenteric lesion up against the brachial plexus. And so I treated him on our MR-Lenic, not because I thought we necessarily were going to adapt each day. And in fact, I didn't adapt any of these fractions. But the confidence to accurately see the brachial plexus, which obviously is mobile, and know that I'm not exceeding the constraint really was powerful. And I think a great example of the confidence, again, that you can treat patients with MR guidance here. And then last but not least, in terms of metastatic disease, taking it a notch further, this is a patient who I treated not with just one, but with two, actually 3 metastatic lesions in the pancreas. So she had a longstanding history of carcinoid tumor of the lung with progression in the liver only. So as opposed to treating each of these in 3 separate plans, it was a lot easier just to treat them all in one plan and track each one of them simultaneously, so that if any one of them exceeded the boundary, the machine would gate off. And so this was a 50 gray and 5 fraction prescription, and she has done just fine. So another example of sort of outside of the box treatment approaches, but one that really sort of makes sense when you think about it. So on the sort of the theme of dose escalation, especially for radio resistant tumors, this is a concept in development now for oligometastatic colorectal cancers that we're putting together a phase 2 trial of systemic therapy plus or minus ablative radiotherapy. Uniquely, this actually will incorporate and really prioritize single fraction ablation. So we have, I'll show you the next slide here in a second, but there's an ongoing single fraction ablative radiotherapy trial for lung, liver, pancreas, adrenal, and abdominal pelvic lymph nodes and kidney lesions at MCI. That's almost done accruing. That has gone very well and is really setting up the next trials looking at efficacy. So I think ultimately, if you're able to ablate multiple oligometastatic lesions, treating each of them sequentially in 5 fractions or whatever it is really becomes very difficult, especially if SABR Comet 10 and other trials showing benefit of treating multiple lesions, shows the benefit there. So if you're able to treat 3 lesions in 3 days versus 3 lesions in 15 days, obviously there's a lot of benefits there. So this again is in development, but something that we're excited about. So to wrap up the talk, I think I'm running out of time here. The last two things are starting to think about a little bit, how do we think outside the box in terms of fractionation. So I alluded to the fact that we are treating more patients with single fractionation. I really never thought about it until the pandemic hit and managed to recruit Percy Lee and Shankar Siva to help cull the data and put this review together. But single fraction radiotherapy outside of the brain and spine really is not very common, although there are cost benefits and convenience benefits to this. These are lung SBRT data from the NCDB that we looked at, and single fraction, despite randomized data being published many years ago, still is almost non-existent in the US. And that really probably comes from geographic misconcern and the inability to image patients with cone beam during treatment. And so if you only have one shot to get it right, you probably want to make sure that you're looking at it and confirming with your eyes that the tumor is where it needs to be. So we have increasingly started treating patients with single fraction, essentially radiosurgery for lung, abdominal, pelvic lesions. This was the very first one we did, and I'll be honest with you, I cherry-picked this patient because it's an upper lobe lesion. It didn't move very much, but the point is that we just wanted to show it was technically feasible, and the patient was done in and out of the room in 40 minutes. These are plans from other patients that we've treated. So this is a 34 gray lung. This was a liver 40 gray in 1, and this is an adrenal met that was prescribed 25 in 1. And so all of these patients were treated in under an hour. Increasingly started thinking about celiac plexus radiosurgery and pancreas radiosurgery, especially given the recently presented and published phase 2 data from that was presented at Astro and ASCO GI. So this is a patient who had refractory pain, just nothing. This guy was miserable in my clinic. He was just, on tons of medications. He was prescribed 25 in 1. You can see it's a big volume. It's not just the celiac plexus, but also gross disease. I posted on Twitter just so you can get a sense. I was amazed by how much interest there was in this, but you can see the plan's pretty hot. So it was a mean of 32.4 and a max of 35 gray. And he ended up 3 days after treatment, just miraculously feeling, his pain almost completely went away. So, so it works. So again, thinking outside the box, you know, can help patients sometimes. This is the trial I mentioned before. I won't spend too much time on this. This is a trial that's almost done accrual. I think we have 1 patient left, but really setting the stage for additional trials. And then last but not least is another population that I didn't think about initially was reirradiation. So if you can adapt the treatment plan and dose escalate and keep your OAR doses, as low as you can, or actually to really what you would want, the benefits of adaptive MR-guided radiotherapy could be profound. So this is a patient who was actually sent to me with recurrent rectal cancer. At the time, we just started our LINAC program. We had protons from day 1. I planned a proton plan. And long story short is because of the conformality of the plan, the small bowel dose was higher than I wanted. So I was just curious, and I asked our team to do a comparison plan for our meridian. So the conformality was certainly better, and the hotspot was higher. And knowing that dose escalation for a lot of these tumors is really where we want to go, ultimately chose the meridian plan as opposed to protons. And we still, obviously, there's a significant role for proton therapy, but this is one case where it sort of got the light bulb to go off, right? And so that has evolved over the last few years to now not just reirradiating patients to 30 to 40 gray EQD2, but increasingly now 40 to 50 gray in 5 fractions after full dose prior radiation. So this is a patient who I just treated. They're typically not as large of a volume as an upfront SBRT case, but nonetheless, we published our initial outcomes data, and for the sake of time, I won't spend too much time here, but a small series in advances in radiation oncology with dose escalation as the theme. The median was 40 gray in 6 fractions, and we saw no grade 3 or higher toxicity, and the 1-year local control actually was quite promising at almost 90%. There is a phase 1 trial that is written and set to open at MCI of 50 gray in 5 fraction reirradiation after full dose. It's a small trial, 10 patients, but we're excited about this to have some prospective data to guide what we do. So last but not least, future directions. So I think we need to do a better job in clarifying indications for adaptive replanning, which patients benefit most from MR guidance versus CT. I think we currently are adapting really almost entirely on anatomic changes, but functional imaging, other novel biomarkers clearly is something that we need to focus on. The cumulative dose across the adaptive fractions is not currently readily available for us to assess. So fraction 1, I adapt, but there's no way to easily account for that in my adaptive process for fraction 2, and then for fraction 3, et cetera, et cetera. So cumulative dose, like we do for brachytherapy, is something that I think we sort of need to look at. Redefining the initial simulation treatment planning workflow. So what I mean by this is, it always bewildered me that we take, at our center, it's 8 days for our care path from sim to sort of treatment for these patients, knowing that I almost certainly am not going to use that same plan for treatment, which we're going to reoptimize in 5 to 10 minutes. So can we get that initial 8-day care path down to same or next day? And so that's something we're actively looking at as well. And obviously throughput, costs, and the resources needed for an adaptive program are not trivial. The last but not least is there's a lot of concern about time that it takes to treat these patients, especially adaptive treatment. With the most current ViewRay Meridian software called A3i, there's a parallel workflow ability so that the physicist, the physician, and the radiation therapist all can do what they need to do for the adaptive process, all in unison. So it's not a serial process, and that has significantly shaved our times down. So I randomly plotted our last 25 patients treated with A3i, 50 gray in 5 fractions. You can see the times, total in-room time. This includes the adaptive process and the treatment delivery. The median time is 45 minutes. So, I would argue on other systems that use motion management, even without adapting, it probably takes you at least 40 to 45 minutes anyway. So these times are actually quite reasonable, and I think there's a lot of opportunity to shrink them even more. So going back to the original case that I did the polling question on, so if you had an MR Linac today and you could treat this patient, who would pick F again? Who would pick E? I got a lot of hands, so that means I guess I convinced you that there's something to this, And going back to Harold Johns, we can't see it, we can't hit it, and we can cure, I think, more patients now than we ever could before, really because of the advances in MRI guidance, and no longer are the days of me looking like Steve Carell we can all be Jimmy Fallons, So with that, I truly believe this is just the beginning of a change in the paradigm of how we treat some of our patients. I think the key again is confidence to know that we are safely delivering ablative dose where it needs to go and avoiding where it doesn't need to go. What once was possible is reality today, and we're just scratching the surface. So with that, again, I thank you for your attention. Thank you for the kind invitation. I'm glad to take questions. Thank you.
Thank you.
Oh, and a huge thanks to our team. So none